don't know me. Probably never will.
But I need you to do something for me.
Something that could literally
Change everything.
You'll never get a thank you card.
And yet, I need you to do it.
And if that weren't enough, I need you to do it as soon as you are able to.
If you do this for me,
I'll do it for you.
And for every single person you love.
Deal?
This is our shot to leave COVID behind.
Hi, everyone. Thanks so much for coming to our breakout session today. I'm Aubrey Villalobos, and I'm co-presenting today with my friend and mentor, Dr. Sahira Long. Dr. Long is the longstanding president of the DC Breastfeeding Coalition, and I'm a board member. Dr. Long is wrapping up in clinic this morning, and she's going to join us shortly. Let me start off by saying that I work for the federal government, but I'm here today in a personal capacity. And Dr. Long and I don't have any financial conflicts of interest to disclose. We have so many people and organizations to thank for their support of the research we're going to share, which was conducted while I was a doctoral student at George Washington University. And these include the coalition executive team and board who were involved throughout the research process, my research mentors and team, the very busy moms in the DC area who generously shared their time and entrusted their stories to us in this study, our community partners who facilitated recruitment, and Mama Tota Village and the East of the River Lactation Support Center for hosting our focus groups, as well as fellowship funding from GW. And thanks to all of you who've joined today. Looking at the list on the WOVA app, we have a broad range of professional backgrounds. So I'm going to do my best to highlight the research in a way that's tangible and actionable in kind of what's my last forum for sharing this research back to the community. So here's what I'm going to cover today. First, I'm going to provide some background on why we undertook this research. Then we are going to summarize 3 studies completed in 2019 and end by sharing some suggestions for how we can increase breastfeeding in DC. And at the end, I look forward to some time for questions and discussion. So let's start off with talking a little bit about the benefits of human milk. Breast or chest feeding is a health promoting behavior with many benefits for both maternal and infant health. Babies who receive human milk have stronger immune systems, fewer gastrointestinal problems and ear infections, better eyesight, lower chance of sudden infant death syndrome, and other causes of mortality. They can also grow to become healthier children and healthier adults with less chance of allergies, eczema, asthma, some cancers, diabetes and obesity, speech problems, cavities, and other illnesses. But there are also benefits to the mom, which include quicker recovery and weight loss after delivery, emotional benefits like less postpartum depression, and long-term health benefits such as lower risk of breast cancer, ovarian cancer, uterine cancer, and endometriosis, arthritis and lupus, osteoporosis, diabetes, hypertension, and heart disease. So breastfeeding clearly has many benefits. Since I work in cancer, I have to share this with you that public health data show there are differences in cancer rates and breastfeeding rates by race and ethnicity. Non-Hispanic, Black, or African-American women are at a higher risk for breast cancer at a younger age and more aggressive forms compared to other racial and ethnic groups. They're also at a higher risk of mortality from breast, ovarian, and uterine cancers if they become diagnosed. We know that lactation reduces the risk of all of these cancers, particularly for younger women and for those more aggressive forms like triple-negative breast cancer. In 2019, 71% of Black non-Hispanic babies born in Washington, D.C. breastfed. Yet, mothers in the city, Black mothers in particular, still experience barriers to breastfeeding initiation and maintenance, which means keeping breastfeeding for a longer time. We have this great opportunity to reduce these cancer disparities by increasing breastfeeding rates. And we know that there are so many multi-level influences that factor into a woman's decision about how to feed her baby. These barriers are often a consequence of the intersection of racialized identity, gender, and class or socioeconomic status. In line with scholars before us, our work operates from the premise that there is no biological basis for race. Racialized identity is therefore socially constructed and is an important influence on health outcomes because it's kind of a proxy measure for experienced racism. I also want to note that we use the adjectives Black and African American interchangeably throughout the research and this writing. The goal of this research was really to dig deeper into the role of norms in breastfeeding in Washington, D.C. to inform public health policies and communication efforts. And norms are those unwritten social rules that are understood by members of a group or a community, and they guide and constrain our social behaviors. So those unwritten rules that we follow. There are two main types of norms that play a role in social behaviors. One is called descriptive and the other is injunctive. Descriptive norms are what we perceive as the prevalence of a behavior or how common is breastfeeding. Injunctive norms are perceptions of what we think should be done. So what are those social breastfeeding expectations in a group or a community? Injunctive norms include both kind of broad general social approval of breastfeeding and those kind of interpersonal expectations or social pressures that individuals put on one another. We applied a theory that suggests that individual perceptions of what's common directly influences behavioral choices or intentions and ultimately behavior. And that social expectations and social identity are two of many things that would influence the relationship. So social identity asks, how does someone identify personally in relation to the group that they're looking to determine the norms, right? Who do I look to for my behavioral cues? Conceptualization of African American identity varies greatly in the literature. And so for this project, we looked specifically at pride, ethnic pride, collectivism, kind of that community support, and also religiosity, because they're both related to culture as well as linked with health outcomes in other research. Our outcome of interest was how strongly a mom intended to breastfeed for 6 months exclusively. And we asked her to report that retrospectively, which means we asked her after she had her baby, we said, doesn't matter what ended up happening with your breastfeeding journey, but what did you intend to do? After conducting the first part of this research, we found that participants shared common experiences of racism related to infant feeding. Dr. Kamara Jones, who's a well-known physician and public health professional and leader, defined 3 levels of racism for us. Our second study focused on institutionalized racism and personally mediated racism. And we chose to focus on these 2 levels because we were looking for opportunities for where could we intervene on the systems and the structures that perpetuate this racism. So what did we want to learn to inform public health communication and policy? The first study explored who African American women in Washington, D.C. looked to for information about how common breastfeeding is and those social expectations of breastfeeding. These are called normative reference. Who do they look to? We began to explore women's social identities related to infant feeding decision making. So who am I when I'm making these decisions and how does that influence my thinking? And then one research question also focused on how breastfeeding norms differed by social position. Does kind of who you're surrounded by change your thinking? Dr. Jones challenges public health professionals to ask, how is racism operating here whenever we want to address disparate health outcomes? So in our second study, we asked, how does racism create barriers to breastfeeding for Black mothers? We also wanted to look for how Black mothers advocate for themselves and counter various forms of racism along their breastfeeding journeys. And then finally, our third study tested that theoretical framework I described earlier, specifically looking at the roles of social approval, social pressure, and social identity informing breastfeeding intentions. I only have time to share the highlights from these 3 studies, but you can visit the articles for more detailed information. And if you don't have free access through your institution where you work, please feel free to email me and I'll send you the full text. We worked with community partners to recruit a convenient sample of 30 mothers who self-identified as Black, non-Hispanic, were between the ages of 18 and 49 years old, and who had a child in the past 3 years, so it was fresh in their mind. A trained facilitator, who was also a Black woman, moderated 5 90-minute focus group discussions with a semi-structured conversation guide. And then she and I coded the conversation transcripts to identify common themes. Here's a quick summary of the sample, and I just want to point out a couple interesting things. We had good socioeconomic diversity in the sample from DC, and good range in age from 18 to 48. Most participants reported a history of breastfeeding, even if only for a brief duration, or with prior children, even if they were currently using formula with their current child. Formula supplementation, we learned, was very common with breastfeeding in DC. And the mother's age at her most recent birth, generational wealth, and whether or not the mother had been nursed by her own mother did not differ by socioeconomic group. So answering our first research question, participants most frequently looked to their immediate family members, especially women in their family, and their close friends. There were variants of how they reported the Black community broadly as what they looked to determine what was common and appropriate, as well as their local geographic community. Healthcare providers, including obstetricians, midwives, doulas, nurses, peer breastfeeding counselors, and pediatricians, were all commonly mentioned and described as important in this decision-making process about how to feed the baby. Partners and fathers were occasionally referenced, but were not reported to have the largest role in the decision-making process about infant feeding specifically. So another research question asked about social identities and what was kind of top of mind when they were considering their personal infant feeding options. Participants reported the identity of mom, as the most important and top of mind, but there were variations. Ethnic pride was apparent for some self-described Black moms, leading to forms of activism. For example, one mom in the higher SES group said, "I purposely breastfeed in public so that people can see that I'm a Black mother who breastfeeds." Single moms typically made decisions about infant feeding based on their finances and work situations, and often described having less support than moms with partners had. Young moms were characterized as having had their first babies in their teens, and participants described them as lacking some awareness about breastfeeding, lacking self-confidence nursing in public, lacking patience, time, independence, or support for breastfeeding. For example, one mom said about herself, "I didn't have a problem breastfeeding, but it's like, 1, you're already getting criticized for having a baby so young. 2, you have to worry about everybody else looking at you." And then the final variation on mom were self-described mature or seasoned moms. They reported that their age conferred self-confidence, so the opinions of others did not matter to them. And given they were entering motherhood later than average, they were determined to do things, quote, right by breastfeeding. So what did we hear about norms from moms, and what differences were there by their social positions? I want to highlight a couple findings. So overall, moms in DC reported that norms were trending in favor of breastfeeding, which is great. But there was some evidence that varied by who they were drawing those norms from and their socioeconomic group. So for example, the middle to higher SES group had strong breastfeeding norms in their close social circles, and but weaker in reference to the Black community broadly. Several reported that they were the first to breastfeed in their family, but noted that among their current friend and social circles, that breastfeeding and for longer durations was the norm. For the lower SES moms, there was mixed perceptions on how common breastfeeding is in DC's African American communities. For example, one mom said, "I actually see a lot more young mothers breastfeeding. I have a whole lot of friends that breastfeed their babies. It's become more common." But another said, "I don't have a lot of friends that breastfeed. I joined a community on Facebook. They said Black women do breastfeed, but I don't know too many. And my mom, she definitely didn't breastfeed." So across the socioeconomic income groups, there was this theme of insincerity in social approval and support for breastfeeding, and we called that lip service. Sorry, I keep checking my phone to see if Sahira has joined us. Many moms repeated the message that they hear breast is best, and they described this trending norm of breastfeeding being promoted and encouraged more often. But mothers also provided examples of how their communities or members of their social groups expressed support for their decision to breastfeed in words, but then did not follow through with supportive actions. Lip service was also apparent in discussions about the public health field and healthcare pushing breastfeeding, but breastfeeding not being enabled by state and federal policies that facilitate mothers staying home and being paid for the duration of the recommended breastfeeding period, that paid maternity leave. Lastly, it was well noted across the economic groups that there was a substantial pressure to return to work that really pervaded the decision-making process for high, middle, and low-income moms, really for everybody. That weighed heavily. Okay, so that was study one. Now let's take a look at the findings from the second study on racism and resistance. Here's a quick summary of the themes that we saw in the data, and then next we'll go through some of the participant quotes and discussion for each theme. So for institutional racism, the themes included the historic exploitation of Black women's labor, institutions pushing formula on moms, and lack of employer supports. But the themes for resisting that racism at the institutional level included economic empowerment and compensation for mothering, and institutions protecting breastfeeding. For the personally mediated racism, it included healthcare providers pushing formula and kind of that shaming and stigma while breastfeeding in public. And then themes for resisting personally mediated racism included moms just rejecting that health provider bias and moms working to build community with each other. Sorry, my dogs are barking. I hope you can't hear that too badly. So let's look at the first theme of institutionalized racism. Participants were aware of this long history of exploitation of Black women's labor, often at the expense of being able to care for their own children. So one woman said, "Black women have always had to go out of the home and work. Black women during slavery were being milkmaids to white families, and they couldn't breastfeed their own babies. So there's several centuries of history in that we are all having to deal with." So recognizing this history helped women push back on narratives that Black women individually were at fault for low breastfeeding rates across time. For some, it also laid the foundation for a new narrative of reclaiming breastfeeding with that ethnic or cultural pride. The second theme in this category was institutions pushing formula, where institutions included the government, WIC in particular, as well as healthcare organizations. So let me read this second comment. She says, "Forgive me, but the government pushes what they want on you. And the government is now starting to promote breastfeeding, but before they wasn't. They was promoting you getting that formula and things of that nature, and that was not healthy for your kids." Intertwined with the comment here was this connection not only to race, but also to lower socioeconomic status. Those moms with lower income, lower resources were a target of this type of institutionalized racism more often, and they had fewer resources to resist it. The final theme in this category was lack of employer supports. Excuse me, I'm giving a presentation. Please go with your dad.
My dad's not here. Papa's not here. He's all the way at the bottom of the hill. And I was
So where were we? So the final theme was this lack of employer supports. So one woman says, most of my network, and when I think specifically family, friends who had kids at the time, and like the work environments that they were in dictated, and the demands of their job dictated more when they would stop breastfeeding rather than themselves being like, I'm done. So it was more like I have to be done if I want to keep working. The lack of employer supports really spanned the socioeconomic groups, from lack of paid maternity leave to established breastfeeding, to no ability to stop and pump in certain types of jobs, to the demands of a high-powered job and an awareness of risks to her career for taking, quote, too much time away. Lower socioeconomic status moms in particular felt this strong push from even within their family members to return to work before they felt ready to stop nursing. So how did participants report resisting this type of institutionalized racism? The first theme here was a nod to economic empowerment and compensation for mothering. One really wanted to feel like it's okay to be at home. This is an important thing that I'm doing, and it's a big deal. I should be compensated for that. Another mentioned that it's really the face of economic privilege. You have to go back to work and grind after a weekend or 2 months or whatever the scenario is. And she was, thinking about a lot of moms who, had a lot of resources, 2-parent households or stay-at-home moms, and they didn't have to worry about that as much, but that it's really a privilege to have protected time to establish that breastfeeding relationship. So, regardless of economic status, participants talked about how important it is to recognize mothering as this, it's a job. We're raising the next generation, and to provide some form of maybe a stipend, noting that more than one participant chose to go on to social support programs to be able to stay home longer with their newborns rather than return to a low-wage job. Paid maternity leave also came up many times in our conversations as an essential protection that needs to be extended to more mothers. The second theme related to resisting institutionalized racism was what can institutions do to protect breastfeeding? So participants gave examples of how helpful the baby-friendly hospital certification is, but we know that communities of color often have less access. And so one mom was having a conversation with another mom here in this focus group, and talking about, whether or not the baby is taken away from the mom in the hospital or rooms in, and whether or not hospital workers provide formula bottles to the baby without consent while they are inpatient. Participants also described the changes in WIC policies and how WIC is now promoting breastfeeding. So in particular, multiple people mentioned loving their WIC lactation counselors or specialists, and really noted even the changes in the WIC food packages that supported increases in breastfeeding. Okay, so now let's turn to the findings around personally mediated racism. The first theme was healthcare providers pushing formula. And this may be hard to hear for clinical colleagues in the audience, but it really was a dominant theme, particularly related to nursing staff in the postpartum ward and pediatricians. But the opposite was true for midwives and doulas. They were really supportive of breastfeeding. So participants felt like their concerns were dismissed and their decisions to breastfeed exclusively were met with skepticism and doubt rather than support and referral to resources. So let me just read this one mom's story. She says, I was very offended and I'm at the hospital and she's like, well, breastfeeding doesn't work for everybody. So let me just give you this in case. But I was like irritated that, and it was like, somebody could definitely use this stuff, but it's like, if I'm telling you that I'm breastfeeding, Why wouldn't you send the lactation specialist in here for a good pep talk before I leave instead of giving me this bag of stuff that I have no intentions on using? The second theme in personally mediated racism was shame and stigma while breastfeeding in public. And while many people feel a stigma around breastfeeding in public, and our study participants didn't really explicitly make this connection between race and class and their experiences breastfeeding in public, we explained in the article that they really are inextricably linked because of this history of white society exerting control over Black women's bodies, their sexuality and reproduction, which really has resulted in cultural norms around modesty that remain today. And participants also described that this stress around feeding in public, combined with other stresses from experiences of racism and economic challenges, resulted in what they perceived as milk supply issues. And that was often met if they went to see a provider and said they were having milk supply issues, that was met with suggestions of formula supplementation rather than health providers referring them to lactation support services. And I have lots of additional quotes to share with you if anyone is in doubt around this theme. But I think based on the last panel, it is pretty pervasive across areas. So how did Black moms in our study resist this personally mediated racism in breastfeeding? The first thing we heard was directly rejecting the health provider bias we described. So what was it that enabled or empowered these women to feel like they could push back on their health providers? Regardless of their socioeconomic status, education about childbirth, breastfeeding, and infant development was key in increasing their confidence to contradict or push back on a health provider. Having access to a support network and being able to navigate herself to resources was also very important and seemed somewhat more common among higher SES moms. So the other thing that was important here was the power of the purse, because moms with the means who were able to choose a home birth or a birthing center birth over a hospital birth, or shop around for a pediatrician who they felt would be more in tune with their parenting choices, that also empowered them to push back. So I'll just read a couple of these. Education was always like a big thing, like knowing that the newborn is going to drop weight. That was one big thing. There was a lot of concerns around that and not wanting to supplement with formula. The other, she was talking about, again, having this knowledge and then being able to shop around and say, new pediatrician, please, right, if you're going to push formula on me. The second theme in resisting this personally mediated racism was moms building community with each other. They described supporting other Black moms and creating spaces virtually on social media, as well as in-person supports to each other to share information and this education, which ties back to the prior strategy. And so that was really great to see. So what did we learn from these group discussions with local mothers? Perceived norms, right, these unwritten rules, varied by who you were looking to draw your norms. It mattered whether you were looking to peers or older generations, whether you were looking to women or what men in your community believe about breastfeeding. Sometimes that varied by economic status. But really interestingly, there was that shared belief around changes in policy and messaging from the WIC program in the last 10 to 15 years, really being a driving force in shifting attitudes and norms to making breastfeeding more acceptable. About identities, we learned that mother was the most powerful identity. But moms held different identities at different times. Sometimes they told stories where they were like, in this situation, I'm a Black mom first. In this situation, I'm a single mom. That really had different connotations for what assets or challenges came up in their breastfeeding journeys. This information helps us think about how we might develop slightly different communication messages and resources for different groups of mothers in our community based on age and generational social support, their relationship status, their economic status, and their beliefs about how common and accepted breastfeeding is. And we'll talk about that a little bit more at the end. So this third study is pretty biostatistics heavy. So I'm going to hit the high points. And if you want to take a look at the full analysis and the story, see the article linked here. And again, if you need the access to the full text, please feel free to email me. We conducted a survey of 528 African-American mothers in the greater DC, Maryland, Virginia region. And we had multiple questions to measure their breastfeeding intentions, 3 types of norms that we talked about, and the social identity variables of ethnic pride, collectivism, and religiosity. We had a geographically and economically diverse sample, and notably, 82% had breastfed their most recent baby, even if, for a brief duration. As expected, we saw that education, mother's age, and having breastfed an older child were all significantly related to having stronger breastfeeding intentions with the most recent child. The norms that we already talked about in the previous 2 studies, as well as ethnic pride, were related to greater intention to breastfeed, as well as you might expect. We used a technique called structural equation modeling to see how the variables were related based on the theoretical framework discussed earlier. We found that only those descriptive norms, so how common breastfeeding is, and the subjective norms, or that social pressure, those were the significant predictors of breastfeeding intentions. General social approval, the IN there for injunctive norms, was not significant when we accounted for all these other variables. So we wanted to test our hypothesis that social pressure influences the relationship between how common someone perceives breastfeeding is and their intentions. We tested what's called the interaction between these norms. And we found that indeed, when social pressure to breastfeed is weak, right? When you have nobody telling you to breastfeed, the relationship between how common you think breastfeeding is and how likely you are to breastfeed is stronger, right? Social pressure to breastfeed has a greater influence on intentions when mothers believe breastfeeding is not common. So this makes sense because if a mother believes breastfeeding is common, she does not need any social pressure to cue her to want to breastfeed, because she's just gonna say, oh, well, everybody breastfeeds, that's the thing we do. But if she believes breastfeeding is not common, positive social pressure can help influence her to choose breastfeeding. And in this model that we ran with education, breastfeeding history, and the norms, 30% of the difference in intentions to breastfeed between, to breastfeed or not, were accounted for by education, breastfeeding history, and these norms. So these norms have a big influence, and so does education. Okay. So the study also examined the role of social identity in breastfeeding intentions. We used a technique called latent profile analysis, and we found 4 different social identity profiles in our sample. Profile 1 was about 19% of our sample, and we called them spiritual mothers because on average, the members in this group had, they had somewhat high ethnic pride, and they were somewhat religious and slightly community-oriented or collectivistic. The second group was named self-reliant mothers because on average, members of this profile had pretty low ethnic pride and low religiosity, and they scored negative on the collectivism scale. So they weren't oriented toward the community as much as maybe a little bit towards individualism. Hi, Sahira, welcome. I am just seeing your text. Welcome, thank you for joining us. I will keep going. And then on the next slide that you and I have for you to present, I will let you take over. Okay, our third group consisted of about 10% of the sample, and we called them ethnically proud and agnostic mothers, because on average, members of this group had really high ethnic pride. They had, slightly leaned towards collectivism or community orientation, but they had very low religiosity. And then the largest group, which was 67% of the sample, we called devout, collectivist, and ethnically proud mothers, because they had high ethnic pride, a high religiosity, and they were very oriented toward community. So we tested that norms model I showed you before, again, to see what influence these social identities had on how norms influence their decision-making about breastfeeding. And what did we learn? So we controlled for education and breastfeeding history, so that was kind of taken out of consideration. And we found that social identity does matter in how norms influence breastfeeding intentions. Specifically, we saw that the relationship was significant for those ethnically proud and agnostic mothers, as well as the devout, collectivist, and ethnically proud mothers. But it wasn't for spiritual mothers or self-reliant mothers. So what does that mean? These results show us that ethnic pride in particular is an important factor in whether or not mothers are influenced by social norms to breastfeed. This information can be used in public health breastfeeding promotion messaging. So from the survey analysis, we learned a few things. Social approval, general social approval, was not a significant influence, probably due because a lot of the sample thought that social approval was generally pretty high in the DC area. The data indicated, though, that if social pressure is weak, a mom's perception of how common breastfeeding is more strongly predicts her intentions. Again, this makes sense because in the absence of pressures or expectations placed on a mom by her immediate family or friends to breastfeed, she might draw her indications of appropriate behavior from peers within her broader social group or from a group she aspires to be like. Pro-breastfeeding focus group participants in our first study, they reported low social approval and no pressure to breastfeed, but they tended to seek out social communities online or in other parts of the city with breastfeeding women of color. And so they were looking then to find women where this was common. Our survey data also indicated that if a mother perceives stronger expectations to breastfeed from important others like family and friends, that her, what she thinks is common matters less. So, again, if you thought that breastfeeding was uncommon in DC, but you receive specific encouragement from friends or families or your health provider to breastfeed, that mattered. And then we also learned that social identity matters. That ethnic pride plays a key role in how norms influence your intentions. As with all research, we had strengths and limitations, and so take these findings with a grain of salt and ask us questions and challenge us on them. We look forward to that. And now I'm going to pass it over to Dr. Long. I think. Do you want to take off from here?
Absolutely. Thank you. And thank you for filling in while I was wrapping up in clinic. So next, we're going to talk about how we might apply these results in communication messaging, public health programs, health system changes and policies to ultimately increase breastfeeding rates for African-American women in DC. Next slide. So these findings support expanding health communication efforts in the DC area to first encourage close family and friends to be a source of positive subjective norms and supports for birthing parents, to use messages and images that increase perceptions that breastfeeding is common in the African-American community, to third, design social marketing with a positive deviance approach and trending norms messaging to capitalize on the successes of local moms, and in doing so, buck current norms that are and hopefully drive a trend towards increasing the popularity of breastfeeding. And then finally, to consider incorporating ethnic pride and collectivism into breastfeeding messaging in audience segmentation. Next slide, please. So how can we take what we learned about racism and resistance in breastfeeding and use it to inform health systems and clinical practice changes? This research demonstrated that racism is a present barrier to breastfeeding at multiple levels, yet most participants were breastfeeding mothers. This means that they found ways to persist in their breastfeeding journey in spite of the very real obstacles that they faced. Maternal and infant health care professionals can join Black mothers in resisting racism on several fronts. First, we can examine our individual biases, the biases in our organizational culture and policies, and actively work to counter them. We can also work to diversify the workforce to increase the availability of culturally congruent birthing and lactation support personnel. And we can work to actively improve training opportunities for providers from medical and nursing schools through continuing education and for advanced professionals. And then finally, healthcare providers have an earned privilege of serving as respected experts in their communities. So this privilege comes with a duty to advocate alongside with and on behalf of Black and Brown women to improve structural and social conditions that would promote maternal and infant child health. So those include, but aren't limited to, avenues for economic empowerment, access to baby-friendly hospitals and birthing facilities, maximizing enrollment in WIC for eligible mothers, and access to culturally sensitive lactation supports, regardless of geography or socioeconomic status. Next slide, please. So here's one example of how Aubrey and I, as members of DC's Lactation Commission, are trying to bring research evidence to inform local policy and practice. The Lactation Commission was developed by our wonderful mayor as one of the first in the nation to have a state, or soon to be state, to have a body within the government, boards and commissions, that is focused on improving lactation supports in the district. And so as a commission, we make recommendations to the mayor and to the Department of Health regarding legislative, programmatic, and policy ways to improve the district's strategies to reduce infant mortality and increase infant and child health outcomes through promotion, awareness, and support of breastfeeding and lactating parents. Two of our recommendations from 2020 were actually informed by the research that we presented today. The first recommendation was to improve prenatal breastfeeding education for mothers and families by increasing pregnant women's enrollment in WIC and access to WIC breastfeeding peer counselors. And then the second recommendation we made based on this research was to improve postnatal breastfeeding support for mothers and families by improving obstetric, family practice, and pediatric providers' education about breastfeeding, ability to counsel families and manage common breastfeeding challenges, and knowledge of when and to whom to refer to advanced professional support. Next slide, please. The DC Breastfeeding Coalition is also working to use this research to inform our programmatic activities. Coalition activities are led by the community. Our coalition members are mostly African-American women and a handful of allies. Many of our members live and work in the communities where breastfeeding disparities are visible and the need is the greatest. So we invite you to visit our website. We also have a booth in the virtual exhibitors. So if you want to stop by and learn more information about us and consider joining our efforts, we welcome that. The DC Breastfeeding Coalition is working hard on trying to help improve the diversity of the lactation workforce. One of the ways that we've done so was to create a scholarship program that helps pay the exam fees for IVCLC candidates in an effort to reduce that financial barrier for those for whom that's a challenge. So we've also created several runs of a lactation certification prep course and a study group to help new professionals prepare for the exam and to get the number of hours that they need to qualify. This has included offerings for the deaf community as well as Spanish speaking trainees. Through grant funding, finally, we provide services through Children's National or in partnership with Children's National Hospital at the East of the River Lactation Support Center, which is located in Anacostia, an area of the city with the lowest income and the highest concentration of African American residents. The center provides counseling, classes, everything, mostly shifted to the classes have shifted to telemedicine because of COVID, but we're still here and in person for any clients that need our support. And most of the clients that we serve are Medicaid insured. Next slide, please. In terms of student preparation, we've also hosted 2 public health practicum students, and coalition leaders have also helped to develop lactation courses and mentoring opportunities for nursing students and pediatric residents. In the past year, we were able to pull together 2 important webinar panel discussions, one during the last Maternal and Infant Health Summit that took place in 2020, and another was at the beginning of the COVID-19 pandemic on COVID-19 and early postpartum breastfeeding experiences. Both offered continuing education credits, and the audience for both had several hundred in attendance. So in spite of the challenges of this lovely pandemic, we've stayed active. Next slide, please. And in terms of advocacy and awareness, we've had a number of initiatives that we've either led ourselves or taken part in from other organizations across the country. So the United States Breastfeeding Committee is the nation's coalition of coalitions, basically, and national nonprofit organizations and government agencies that is working on moving the needle nationally in breastfeeding. And if anyone's interested in taking part in their advocacy efforts, there's always, they keep a finger on the pulse of federal legislation, local legislation, anything going on across the country. And they always send out opportunities to get involved, and you don't have to leave your house. As long as you have a computer, you can participate and sign on opportunities. We've also been able to do local testimonies with the DC Council advocating for breastfeeding issues, and we're able to receive funding through a Title V grant from DC Health to support the East of the River Lactation Support Center and some of our work with birthing facilities. We also host a Breastfeeding Friendly Workplace Award and Healthcare Provider Award annually. The only year we took off was 2020 due to COVID, but we're gearing up to do it a little differently this year to respect that COVID is still here and has not let up its grip on us. And we're actively in the process of updating our breastfeeding resource guide. Right now it's in English, Spanish, and Amharic, and we expect to do the same for the version that we're doing now. The app is available only for the English version. And we're still offering breastfeeding classes to any expectant parent that's interested virtually. Most of those in the past were in person, some in partnership with the teen parent programs through New Heights. And now that schools are back in place, we'll have to see if that's something that we can get going again. Next slide, please. So we're also working this year on a few new items. Paid family leave is important for not just helping with bonding, but also helping to get breastfeeding off to a good start. So that's one thing that we're trying to pour our efforts into to help advance. We're also advocating for educating the community and employers about workplace protection for nursing mothers. In the past, with help from the funding support from DC Health, we've been able to help every facility except for probably one that's been designated as baby friendly in DC through their journey. And we're hoping to continue that work in the next year of our grant. And then finally, we're also advocating for increased advocacy, increased accuracy and access and timely access to breastfeeding data so that we're able to better evaluate local efforts to increase breastfeeding rates and eliminate racial and ethnic disparities. Next slide, please. All right, so we've said a lot and we want to give an opportunity for you to ask any questions that you might have. We are super thankful that you joined us for today's presentation and gave us an opportunity to share the work that we've been doing. And we look forward to your questions and a robust discussion about more things that we can do in DC to protect and promote human milk feeding. So I will tee up the chat box.
Thank you. Thank you so much, Dr. Long, for going through that and for joining me in this research and for mentoring me along the way. You know, it was really a good learning experience for me as well. One question came in that asked to clarify what ethnic pride refers to, and I apologize I didn't do that sooner. You know, the kind of the definition of ethnic pride is really, you know, having positive attitudes toward and feelings of belonging to or connection with a particular racial or ethnic group. And I think we, you know, maybe had 5 or 7 questions that on the survey that respondents answered on kind of on a scale, and that turned into a score for ethnic pride. But that's the definition. So the questions were getting at kind of positive attitudes and feelings of belongingness or connectedness to kind of the you know, the Black community in this case of this study. Any other questions that have come in? I don't think so. Sahira, do you have any questions? I feel like this is the last time we're going to be presenting this research. So any you know,
my only question is what are you envisioning researching next, or where do you see taking this research? Like, what's the next step?
Yeah, I mean, I would love to see someone, not me, because I can't in my current position, but you know, I would love to see the coalition work maybe to you know, pursue some funding to actually develop some communication messaging and some you know, yes, like a social marketing intervention specific for DC, building on these findings, and you know, having a local campaign, you know, in partnership maybe with DC Health. Doesn't have to be with WIC necessarily, because it can be for, you know, a broader community than just who WIC serves. But I would love to see that, and that can be done, you know, as a public health research study to develop and test how effective that is, and I think would really be a great benefit to the community. But again, as we've said in all of our papers, you can't just tell people to breastfeed, you have to make it easier for them. And so I think the work that the coalition is doing, and, you know, and the Lactation Commission recommendations are really aimed at addressing some of these policy barriers. And I'm really excited about the work we're doing on the coalition around trying to raise awareness around DC's new paid leave and getting more moms who could really benefit from that to enroll and receive those benefits. And yeah, I think those are some of the things I'm really excited about.
And this year, one thing we didn't mention that we're hoping to do this year is, in addition to workplaces and healthcare providers that are breastfeeding friendly in the district in Maryland, we're hoping to add a breastfeeding friendly daycare award. So if we're able to sort all this out, I really can't thank the daycares that managed to stay open through this pandemic enough for the support that they've been to families, and feel like they need some recognition at this point. So hopefully we'll be able to do it. Stay tuned. In the next month, we hope to launch the awards. And if you have a breastfeeding friendly employer, or if you believe your healthcare provider is breastfeeding friendly, then we encourage them to to let you nominate them or nominate yourself.
That's great. Did you, let's see, we do have another question that just came in. Says, hi, Sahira, as we gather more data, more women living with HIV are choosing to breastfeed. Is there any planned messaging around that specifically?
So the planned messaging has to wait for that data to reach our Centers for Disease Control and Prevention, because still at this point in the United States, the recommendation is, even with controlled, well-controlled HIV, that women not breastfeed. And so we need that data, Dr. Denson, to reach the powers that be that make those recommendations. Globally, it's a different story, where having a safe alternative is not always easy to come by, or a safer alternative. And so the recommendation in countries without safer alternatives to feed babies is to breastfeed, and breastfeed exclusively if you have HIV. In this country, that hasn't been the message. Hopefully you can bring that data forward and help push that change.
Thank you. That's a good question, and good response. No new questions. I have a question, since this came up recently. Maybe this is premature, but we did talk about, trying to do some initial research to see if it would be helpful to have some educational material around breastfeeding for vegan families. And I don't know, we haven't embarked on that yet, but let us know in the chat if that's something that you think would be helpful or useful in the DC community, or if any of our lactation providers or other clinicians have encountered questions or challenges around supporting breastfeeding families who follow a vegan diet.
Yeah, and my plan is for that is, also I'm a member of the executive committee of the AAP section on breastfeeding, is to see where the AAP stands, like what resources are already available, because I'm a fan of not reinventing wheels that work.
No, we don't need to be creating anything. We don't have time for that.
No.
Yeah, no, that's good. Okay, and I see we only have 3 minutes left. Sahira, are there any other things going on in the coalition that you want to let people know about related to the lactation certification prep course, or anything? Oh, the resource guide that's going to come out, the new resource guide.
So the resource guide is in the final stages of editing for the English version, and then it'll get translated, or the parts that have changed will get translated into Spanish and Amharic, and we hope to have it ready at the latest mid-October. So
okay, mid-October for the new updated resource guide. And how can community members and partner organizations and clinical groups get their hands on that to be able to get it to families?
So there will always be a PDF version. It's downloadable, printable on the website, and we will print some copies that we send to our hospitals and birthing facilities in DC, and any organization that would like some can reach out. We can probably mail a few or arrange to have them picked up.
Great. And that website's dcbfc.org. One last minute question came in here. Any early findings on tele-lactation success versus traditional? And I'll just say, this is something I've been trying to organize a webinar around to document just that and have that conversation with some providers who've been providing tele-support and talk about that. We have not been able to line up enough speakers yet, but stay tuned. Hopefully, before the end of the year, we'll try and pull that together. But Sahira, how about in the East of the River Center, how's the tele-lactation going?
So we have, through the pandemic, maintained an in-person presence because the East of the River Lactation Support Center is housed within a pediatric facility that stayed open through the pandemic. So we weren't, we didn't transition the majority of our visits to telehealth. We are doing more telehealth support for community consults, and also for some of our WIC families, since WIC is doing mostly virtual support or remote support for families through the pandemic. So can't say, I haven't actually looked to see what findings are comparing the two. Because
Yeah, no, I haven't
the
seen any
majority of what we're
comparison come
doing.
out yet. I mean, anecdotal feedback has been that it's been positive, but it can't meet all of the needs, right? Sometimes you need to put hands on a patient and, but it can certainly fill gaps and increase access for certain needs. So it looks like we're out of time. I see a couple very last minute questions came in. If you want to put those in the WOVA app, we can try and respond there, but I think we're out of time for today. So thank you so much for joining us, everyone.
Yes, thank you.